Hey everyone, my name is Haley. Today I will be discussing topic 9, which is regarding the competency to make treatment decisions. In this presentation, I will be speaking on Chapter 11, Section 1 and Section 3 of the Psychological Evaluation for the Courts, book by Melton, and a media source for additional information on the topic of informed consent. Melton states that a mental disability does not, by itself, imply incompetence. The presence of a mental disorder only raises a question about whether specific functional incapacities render a person unable to make a particular kind of decision. Some common questions about competency include: should an individual committed to an outpatient treatment facility be restricted in their rights to control property or even marry? And should an individual with intellectual disabilities who have trouble conceptualizing large amounts of money be restricted in their use of money, even when they understand the concept of cash and small transactions? Self-determination requires more consideration than an individual knowing what is best for themselves. This means that just because an individual can make decisions under the assumptions that they are operating in their best interests, doesn't mean that they are or that they have the capacity to understand what is actually in their best interest or the interest of other individuals surrounding them. Self-determination may be overruled in cases where harm will come to others by the actual actions of the individual, or they are incompetent to make the decision of concern. The definition of competence varies based on the context of the situation and case. From a treatment standpoint, a physician may be more lax on the definition of competency when it comes to an individual accepting a beneficial treatment that has few complications, and more strict when it comes to a patient declining a beneficial treatment. Alternatively, a physician may be more concerned with competency when it comes to a patient's willingness to try a highly experimental and little-known treatment than they would be when it came to declining such a risky treatment. There are 3 requirements for informed consent to be valid: disclosure, consent, and voluntariness. Informed consent is crucial for any type of work with individuals when it comes to their care, such as medical and psychological. The adequacy of disclosure is crucial to the disclosure aspect. Up until 1972, judges based the adequacy of disclosure on whether the physician's disclosure was similar to a reasonable clinician under similar circumstances. The second approach is from the patient's perspective and what a reasonable person would disclose. In both elements of disclosure, the facts hold the same. The nature of the recommended treatment, its risks and benefits, and alternatives to the treatment. Many states hinge on the first perspective, especially in circumstances such as malpractice suits, due to a physician's knowledge and expertise in deciding what procedures are beneficial and what are dangerous based on each patient's case. Competency to make treatment decisions is usually presumed, except in cases of groups of uncertain competencies, such as those with disabilities, the elderly, or children. Despite this, the issue of competence is only raised when an individual refuses treatment, especially a prescribed beneficial treatment. Even in the case of severe mental illness, if an individual is following along with the treatment and agrees, their competence is not questioned. De jure incompetence occurs in the case of a minor, and de facto incompetency is the case of a legally sanctioned case, such as that of abortion. In all of these cases, competency evaluations are more often than not warranted due to litigation awareness compared to actual concern for competency. Voluntariness is a legal issue rather than a mental health issue. This makes clinical conceptualization difficult. The separation of competence and voluntariness appears not to be sound. This is due to an inconsistent conceptualization in the courts. One court worried that the institutionalization may leave patients unable to consent to treatments that may be invasive. Additionally, courts have chosen to see hospitalization as voluntary, despite patients either not knowing their legal status or choosing to be voluntarily committed in order to avoid being involuntarily committed and losing their freedoms. The video that I attached summarizes the trifold of informed consent in a more concise and kind of basic manner with some helpful, simple graphics.
Hey everyone.
The discussion question that I came up with based on all of the information in this PowerPoint is, should more emphasis be placed on ensuring individuals understand the facets of informed consent and having an actual conversation to ensure their understanding rather than simply using a disclosure form that may be lengthy and difficult to understand for laymen? And here are my references for Melton's textbook, as well as the YouTube video on informed consent.